is an online portal webinar series hosted by Father Muller Homoeopathy Medical College, Mangalore. It is a platform provided for homeopaths all over India to enhance their knowledge by listening to the standards of homeopathy. Here I have the pleasure of welcoming our administrator, Reverend Father Roshan Krasta. I would also like to welcome our principal, Dr. Shiv Prasad sir, and Vice Principal, Dr. E.S.J. Prabhukiran sir. A warm welcome to our today's guest speaker, Dr. Amir Ashraf, to ProVision 2020. It is my immense pleasure to welcome the moderator for today's section, Dr. Hafiz Sharif from Surgery Department. Now I hand over this section to Dr. Hafiz Sharif. Over to you, sir.
Good evening. It's my privilege to introduce the speaker for today, Dr. Amir Ashraf, our own alumnus and my junior in the college. He completed his BHMS in the year 2013, and thereafter he worked in various homeopathic hospitals in Kerala. He worked at Ashirwad Hospital at Kannur from 2014 till 2019. In June 2019, he began a new venture and set up Dr. Amir's Family Homeopathy Clinic at Kannur. He is currently a visiting consultant at RM Homeopathic Specialty Clinic, Calicut and Malappuram, AIHMS Multi-Specialty Clinic at Wayanad, and Noble Child Development. To add to his credit, Dr. Amir has also presented many research papers, both at national and international level. To name a few, effectiveness of Conium maculatum 200 in the management of pyuria in September 2017 at Kottayam, effectiveness of homeopathic medicine on renal hypoplasia at the 22nd World Congress on and Perinatology Conference at Hong Kong in 2019 September. Effectiveness of homeopathic medicine in the management of bronchogenic carcinoma at the 4th International Conference on Integrative Oncology at Kochi in the March 2020. Today, he will be presenting on the topic Think Homeopathy Before Surgery. It's our pleasure to hear you in today's session. Over to you, Dr. Amir.
Yeah, is it audible? Hello.
Yeah, you're audible.
Yeah, okay. So is the slide okay?
Yes, yes.
A very good afternoon to one and all. First of all, I'm grateful and thankful to the organizing committee of ProVision and yet my junior, Dr. Dheeraj Fernandez, for the invitation. I'm also extremely thankful to the principal, Dr. Shiv Prasad, sir, and also the vice principal, Dr. Prabhukiran, sir, and my beloved teachers. And very deep-hearted thanks to my dear senior, Dr. Hafiz, our own Hafizka. This is my topic today, Think Homeopathy Before Surgery. So you must be dealt with some of the cases in your own clinic regarding a surgical diseases. And you must be experienced one or another method and an one-way session. And I'll start with my first case. Hello, is it okay?
Yes, sir.
Yes. So the first case is 20-year-old female came with complaint of abdominal pain, nausea since 2 days. Onset of pain was at night. So she consulted a RMO at nearby multi-specialty hospital So they prescribed some medicines along with some injections. There was no relief. So she shifted to another physician and they underwent ultrasonography. So this is a presentation she came to me, that abdominal pain in the right iliac region, especially I can say it can be also right lumbar, with history of pain radiated to umbilical region. The way she sat over the chair can make out that the pain. She was not able to bear the pain. The slight movements make a severe pain. There was a history of vomiting, and the nausea since was present and it was continued. And there was also a loss of appetite. Mild fever during the onset of pain. That means 2 days before. So with the present history, what can be the possible diagnosis? What can be? A young lady around 20 years came with abdominal pain in the right iliac region, with the history of vomiting and with the history of fever. Yeah, there are a lot of comments from Dr. Sonia, from Dr. Sarida, Dr. Sunida, Dr. Abida, Dr. Aguilar, Dr. Swati. Yes, exactly. There was also, it can be a possible ruptured appendicitis with the peritonitis. Well done, doctor. Last LMP, yeah, it was not on the day, not on the day. So with the history, we moved to on examination. There was no difficulty in while passing bowel as well as the bladder. Yeah, it can be organized, good one. So yeah, molar pregnancy, good one. On examination, we could find that there is a temperature, but it wasn't suppressed. You know, she was taken out of the tablet in the morning. She was came in the morning. And the importance of this case is that this case has been referred from an audiologist from Dubai. That was during the lockdown. That shows the importance of homeopathy during emergency situation. On examination, localized tenderness present. Muscle guarding is present. Rebound tenderness is present. As we all know, the way how we examine the muscle guard as well as the rebound tenderness. Good on ectopic pregnancy. Yeah. And there was a sign of positive in the Rowan sign and the negative in the obturator sign as well as psoas sign. I just come with a, you know, the Rowan sign, you know that how when you give a deep palpation over the left iliac fossa and the pain which causes in the right iliac fossa, the classical pain, the McBurney's point, what we suggest is one of the clinical diagnosis for appendicitis. And I'm mistaken, it's not a like classical sign. The classical sign is the previous one which I mentioned. Sorry. And as you all know about the psoas sign as well as the obturator sign. Yeah. This is a report she came with. Appendix, which is measuring up to 40 millimeter in diameter, with periappendicular fat edema, which is seen in the right inguinal fluid, suggestive of an acute appendicitis. The 40 millimeter in diameter, the size. So soon after they advised for a surgery, there was a severe pain, and which is unbearable pain. So as a look of an appendicitis, a clinical way, like I was using these remedies for the last 6 years, and I was also guided by one of my uncle and also my senior doctor in my hospital where I worked. So the last 6 years we have been seeing all kind of appendicitis, and out of this box I can suggest some which uses for perforated appendicitis like Arnic and Nephrosis, which has been clinically well affected. And I too remember one of my senior, Dr. Nisha Bali from Calicut. He also has so many cases of like an appendicitis. His favorite medicine is tagline for RX 10X. But I prefer Bryonia and Echinacea when it is like an, the formation, first leg formation, which is seen in the suppurative appendicitis. Here, for this lady, the young lady, we had given Belladonna 200, 3 pills hourly, and sulfur 1 daily for the 5 days at the bedtime. And we also asked them to report if there is any severe kind of pain. On 13th, she came with a report suggesting that the pain was reduced, nausea reduced, but still there is a lot of loss of appetite. And her examination findings, which reveals that there is a positiveness in the tenderness again, which also suggests in the USG that there is no prop tenderness. And there is a negative sign in the roving sign, as well as rebound tenderness and the muscle cardiac. So we continued the same treatment for the next 7 days, and we had given sulfur 1 SOS to a safer side. And this is after 7 days. No complaints of pain, no nausea, appetite improved, and there is no fever. It took just around from 7 + 5, around 12+ days with the Belladonna initially and sulfur 1. Our examination which reveals tenderness negative, muscle guarding negative, and rose sign negative. So we advised for a follow-up of the USG, and we continued Rubrum 200 TDS for 3 days. And this is a report. There is no signs of an acute appendicitis in the latest scan. And she also has a bilateral PCO in the previous scan. That is exactly what is seen in the new scan also. She was under another gynecologist for the same. So this is like, I would like to mention, when you treat a case of an appendicitis, never ignore the physical symptoms. Physical examination, sorry. And clinically, we can see, like, if you consider a patient of a male infant, if they present with a hemiscrotum due to migration of an inflamed appendix, how you can initially misdiagnose to be an acute testicular torsion. It can be due to migration of an inflamed appendix, yeah. And studies are still going on with the increase in WBC. We can't hardly sure to say that increased WBC is a factor to assess a case as appendicitis. And it is still stand to be a non-specific. And next one, the C-reactive protein. As all you know that, it is an acute phase reactant which is synthesized by the liver in response to infection or inflammation, and rapidly increases within the first 12 hours. But C-reactive protein, CRP, it is reported to be useful in diagnosis of appendicitis. However, it still lacks the specificity, and it cannot distinguish between the site of infection, where the infection has been placed. But very high level of CRP in patients with appendicitis, it can indicate of a gangrenous evaluation of the disease. That was our latest study which is going on. been associated with the leukocytosis and as well as neutrophilia. And the last one, urine analysis. It can be useful to differentiate appendicitis from a urinary tract infection, because a mild urea may occur in patients with appendicitis. The common anatomical relationship between the right ureter and the appendix. Treating appendicitis can be uneasy, but maintaining appendicitis patient is a bit difficult. So you have to say about the diet, what to eat and what not to eat. My friend, my colleague, Dr. Binsi Pichako, she's working in NGO in the mental health, who also completed the MPH. She helps me a lot during the crisis for the diet management. Especially we used to communicate with the patients with email to assess what to eat, because she has having a strict diet plan. So since after the correlation, we used to advise the patient what kind of diet the patient has to undergo. So we suggest the foods like vitamin A, carrots and sweet potatoes, a good source of vitamin A. It can be consumed with the other food what she has. And the vitamin C, foods like orange, guava, lemon, and the vitamin D. As you know, it's one of the important functions for the healthy body, and which can include the eggs, fish, cheese, and ginger, but not in higher content. As you know about the zinc as well as omega-3 fatty acid. And similarly, you have an option what not to eat. You have an option of what to eat as well as what not to eat. High fat food, because it is a very strict to no, say no, because it is very hard to digest. It can contain the meat, cooked egg, cheese and whole milk, and chocolates, ice cream, fried foods, and preparations having much mixed with the butter and oil. Food with high sugar content, like sweets, candy, cake, muffin sweetness, and creams, it can also aggravate the condition what you have been treated. And the canned foods and juices and aerated drinks. So moving to the next case, a 4-year-old boy, he came with a severe right lower quadrant pain, nausea, vomiting with temperature around 99. He also has a recurrent lower respiratory complaints. He has been suffered from a bronchopneumonia very recently. Because why I say is that when you're treating a cases like appendicitis, you must be keep in mind a DD, lobar pneumonia and pleurisy, especially the right base. It can give rise some kind of an abdominal pain, and that can mimic appendicitis. Abdominal tenderness will be minimal, but the pneumonia fever will be very high. The paraxia will be very marked. And also you can have a mind when you treat appendicitis as a DD, about symbol like mesenteric lymphadenitis, which is nowadays is very common, and intussusception. How do you differentiate the appendicitis from intussusception is, the intussusception, the median age is 18 months, but appendicitis is very less or very uncommon before the age of 2 years. Moving to the case again, 4-year-old boy, he has a severe right lower quadrant pain, nausea, vomiting with a temperature of 99. You can see the report on the screen, which suggests appendix which measures 3.3 in outer diameter. There is no periappendicular fluid which is demonstrable, but there was a moderate probe tenderness, which is elicited in the right inguinal fluid. The features which suggestive of an subappendicular inflammation. There is also a small mesenteric lymph nodes which enlarged in the right iliac fossa. We started the medicine, belladonna 200, 3 pills hourly, and Briona 200, 3 pills hourly. And after giving belladonna and Briona, we could see the follow-up as they have called in the morning and suggested that there is no pain and there is no fever, and there is also no nausea as well as vomiting. So when they came, we directly sent them for the repeated scan, and we could see that there is no evidence of an appendicular inflammation, which is demonstrably present, and there is a presence of a mesenteric lymphadenopathy. There is no tenderness present since after it we just examined. This is a 2 case which I want to discuss about appendicitis. There was a question which arose was why sulfur 1N? Treating a remedy based, the selection of sulfur 1N is to complete the course, especially when I'm treating with appendicitis. It acts well once you complete the sector remedy and giving sulfur 1N found that it is having good action and there was no recurrence. Higher potency was not given to our reputation. Treating a cases from hospital, while we advise a patient for an admission, and on the hospital chart we need to repeat the medicine. We cannot just write one dose as such. So moving towards the next case. This case has been referred from my senior, Dr. Sabik from Calicut. The patient is under his consultation for cerebral ataxia. There was a call came in the morning from a child parent, father, suggesting of a pain abdomen on 26th of June, which is around umbilicus, which is aggravation from pressure, and the pain was seen around night. Appetite was reduced for last 2 days. There was a mild fever developed on morning, weakness since a day, bowel not passed on a day, and there was a heart stool on yesterday. And there was a pain was developed after eating biryani. And there was an episode of vomiting. So with the available data, what can you suggest for the diagnosis? A young girl developed a pain abdomen at night, and there was aggravation from pressure. Pain was developed after eating biryani. There was an episode of vomiting. There is a weakness, and there was mild fever since morning, and appetite was reduced for last 2 days. Any suggestions for diagnosis? Yes, Dr. Revati, colitis. Any more suggestions? Colitis. From Dr. Jyoti, yes, colitis. Any more? Gastritis, yes, good. Dr. Sunita. What can be? Food poisoning, eggs, good. Asal, not good as such. And I forgot to mention she had started her menstruation on the previous day. Acute gastritis, acute appendicitis, food poisoning. I missed the point that she started administration on the previous day. What can be? Actually, I didn't interfere in this case because Dr. Sabik was dysmenorrhea, good. Dr. Sabik was treating this case for cerebral ataxia, primary dysmenorrhea. It's good. So he was giving his own, constitutional remedy. So I started with the MAC4/6S, considering as it can be a primary dysmenorrhea. Keeping in mind, because that was the moment I just given MAC4/6S 2 tablets 4 times a day. So she reported well. She reported on 27th that pain was mild better. On 28th, the father called in the morning and said she vomited after drinking water. So pain developed again. So we advised for the USG abdomen. So we could really say, okay, this is not a dysmenorrhea, something related to this. So we advised for USG, and this was the report. We could find that gallbladder is distended. Yeah, pancreatitis is a possible cause. The severe pain, Dr. Chandra, yeah, it will be a severe pain. Patient will be dying to get out of the pain. We found the scanning that the wall thickened 4.5 millimeter with edematous, shows a calculus measuring about 11.6 and 12.6. Calculus is noted in the neck of bladder, which is measuring 12 millimeter, which causing the obstruction. And also there is a small 5 millimeter in the upper calyx. So based on this, we moved with the medicine. We discussed with Dr. Sabik, and so we need to interfere with some of the pain remedies. So these are my sorry. These are my 4 remedies which I used for treating cholelithiasis. Very common remedies. And I differentiate these 4 remedies with my small points. First of all, I'll start with the cardasmer. The only remedy which I find while examination tenderness is marked, which has a better action than other 3. Once you have a try with Intinger or 0/3 or 200, cardasmer has a good action, especially when you find the tenderness, marked tenderness on examination. And all, Chelidonium, Chinanthus, Berberis all have a common feature as jaundice. But Chelidonium, it has a particular feature that very sluggish in bowels, and it will be more of lethargic weakness and more of a stitching pains. Coming to the Chinanthus, the pain will be always inlocated with the umbilicus. There won't be no appetite, very loss of appetite, and severe colicky pains. And Berberis, as you know, is a multitasking remedy because it is good for renal as well as a gallstone colic. So I just call them as a multitasking because it has a tendency of a radiation pain. It can move from right upper quadrant to which can extend to the stomach. The extension of pain from kidney can travel to the liver. It can travel to the spleen. It can travel to the stomach and groins. So we started with Chinanthus Q along with the cardasmer. How we get into this patient was 20 drops each. 20 drops, one Chinanthus was mixed in 1 glass in quarter of water. 20 drops of mixer. Similarly, cardasmer. And we asked the patient to take 1 teaspoon in 15 minutes alternately. And we got the follow-up on 30th, on 5/20/20. The pain was better, and I done my part and I referred back to Dr. Sabik. And she has been followed with Dr. Sabik for 2 hours. In his consultation, my native in Kannur, she's totally fine. There is no episode of pain since after administering Chinanthus as well as cardasmer. This is all about symptomatic gallstone or cholelithiasis. Once you come about asymptomatic, yeah, very lucky to be working in hospital is that you get a reference from unexpected reference from the allopaths also, because they knows better than we knows where we have the most actions, where we have a deep-seated actions. This case has been referred from my hospital. She had some kind of fibroid issues, uterine fibroid issues. So they consulted and find this so-and-so complaint, and they ask for suggestions to go with the homeopathic medicine if they have some medicines. But it's very asymptomatic. So in this kind of treatment, asymptomatic treatment, I always find, especially for females, pulsatilla is one of the good remedy. And along with pulsatilla, chelidonium tincture. The tincture used to apply over 5 drops over a morning as well as a night. On this report, we can see that there is a gallstone around 50 millimeter, and there is also an enlarged uterus with multiple small fibroids, which can be measured up to 10 to 20. On after 3 months of treatment, because as it is a asymptomatic case, we won't find any much symptoms. So she used to come over once in monthly. I mean monthly once. So we used to repeat it. Pulsatilla only once in 15 days, and chelidonium for the 3 months, 5 drops into morning and night. And we could find that there is no gallstone present, but we found in the previous report there's a small multiple fibroid, but here we could find only this single fibroid exceeding around less than 20 millimeter. So I'll move to the next one. Okay. This case was very interesting for me because it was during my initial days of taking challenging cases, when I was felt that okay, I'm fit to confident to take some cases because to take some risk in the clinical career. This case is about the baby is around 1 month, hardly 30 days. Baby came with a severe pain during urination. Child screams and scribbles due to the pain. The urine passes in split and drops, but not in a continuous motion. Baby cries throughout the night once he passes the urine. It was just since for like, there was no slide because it was a USG report. That's only the reason. Sorry. Baby was under the treatment for allopathy, so they undergone a report. So this is a presentation which came to me that 30 days of age baby came with complaint of severe pain during urination. Child is screaming, scribbling due to the pain. Urine passes in splits and drops, but not in a continuous motion. Baby cries throughout the night once he passes urine because of the pain. Baby was under mild fever, and which recorded was a 99, and there is no hematuria. Baby sleep for shorter duration, and there was kind of a chill every after sleep. And nobody likes to touch him because once you touch, he cries like anything. Sorry, because of the pain. So do you have any kind of suggestions with the available data?
Excuse me, doctor.
Yes.
Your slide is not visible. Only 2 black lines are over the screen now.
Yeah, it is about to come a USG report. One slide was missing, so that is only the reason.
Oh, okay, fine. Okay.
I'm sorry. So Can you have any suggestions for the diagnosis? I know there is no slide. Baby of 30 days old, screams of severe pain, scribbling due to the pain, which passes in splits and drops on a continued motion, and cries throughout the night once he passes the urine. Yes, ma'am. That is phimosis, yes. Phimosis, yes. Okay. So initially, I can be felt that okay, it can be simple UTA, but they came with a report suggesting that it is due to sorry. It is due to the hydronephrosis, and you can find the left hydronephrosis. So we can also see the right kidney above the pelvic, fullness of the pelvic calcium system. So initially I took a reference from my angle over to the pediatric surgeon. So what can be the possible diagnosis? So we could find can be a possible urethral stricture and possible obstruction. That's all that we felt. And so said that it has to be operated. It needs a surgical intervention. Patient family trusted the homeopathy. We started the medicine. I discussed with my uncle, the Dr. Amir Ashraf, and okay, we felt okay, we'll wait for 72 hours. With the available symptoms, we moved with Sarsaparilla 30 in aqua. Sarsaparilla 30 in aqua because symptoms like considering the bladder urination, dysuria, painful, and before the urine starts, and it's one of the good remedy for the renal colic, infantile colic, and the urination symptoms like child screams before and while passing urine. And we also know some other symptoms like the drops which pass the flow of urine is very low. So we give along with Apis mellifica 30, similarly 5 drops in distilled water 50 minutes alternatively because of the intense thirst and chill, sleepiness, and suppressed urine. This was the first case of hydronephrosis which I've seen in my clinic. So, as you all know, it is present when the urinary retention has led to thinning the renal parenchyma. It can be possibly the blockage at some part of the urinary tract, or can be due to the reflux of the urine, or it can be congenital. So after giving Sarsaparilla and Apis mellifica, on 28/4, we could see the pain has been reduced, and pain still persists during night. Fever is better. So we continued the medicine for another 15 days. And we used to give, initially was 15 minutes interval. So it has been shifted to 1 hourly. On 12/5, we could see that pain has been reduced. There is no scream at night. There is no fever. And we advised for the USG once again. And we could see that flow of urine has been improved. It was a split wise, but it was improved. It can be possible cause of an obstruction during in hydronephrosis. The possible cause is obstruction. It can lead to split urine streams. And once after going for USG, we could find that there is no signs of left hydronephrosis, as well as on the right pelvic, that is what was been observed in the last one. Yes, sir. So moving towards another case. This case was very interesting because they are from my residence area. So early morning around 6:30, one of the granny in the house has been called and asked, "Doctor, do you treat appendicitis?" I was repelled. Yeah. Oh yes. What happened? No. Our grandson has developed appendicitis. Okay. So I think. I mean, why do you think such a way that he has developed appendicitis? No. He has developed a series of pain, and he was not able to sit, or he was not able to walk, and not able to. I mean, he just cries out. So I just asked, how do you conclude it's an appendicitis? No, doctor, it is just my query. So I asked them to come. So they visited. So soon after, because as we know, all the mothers at our house can be a junior doctor. So soon after they came, I asked the boy to lie on the examination table. Father was just giving an explanation that he had a chicken fries a lot yesterday, so that can be leads to a severe pain. So soon after I was just going for an examination, the boy narrated that he has a pain here, the right side of abdomen, possibly the right quadrant, which radiates to lower back and sides, present along with nausea and mild feverish, but no temperature. And he has a constant feeling to urinate, but the flow is very limited. Basically, I know him because he used to consult me. He doesn't pass the urine in his school because of the hygienic. What he say, like, it smells a lot. So recently, I had treated him also in UTI. Looked into the tenderness, which was mild present, but there was no muscle guarding as well as rebound tenderness. So I asked him, can you go for an USG abdomen soon before I try some medicines? So even I asked the boy, do you have an exam today? I said no. So we went for the USG and we could find that there is a possible of my left hydronephrosis and hydroureter, which was creating a pain. And there is also given that it can be possible of acute appendicitis, which can be ruled out. So soon after this report, I just went back and I need to look for the appendicular signs. Roving sign was negative and the negative obturator as well as SOAS. So with the available symptoms, I just moved forward the belladonna 200 hourly along with Apis mellifica 30. It was a considering of the pain and the urine outflow and the frequency of urine frequency and also its tendency of that. They had called me after giving the medicines. They had reported me on the evening that I was mild better and asked them to continue. And after 2 to 3 days, he had came. There was no pain since after taking the medicines. And a bit of nausea was there initially, but it was been improved. And there was an improved urine flow. As also, urging was reduced. So we asked them to continue Apis mellifica 30 again for the last 2 weeks and advised to go for an USG. And this is a report. With this report, I just went back for examination again because it has a point to correlate again, to roll out. We could find that, okay, it's a possible, we could find that visually solid abdominal mass and pelvic organs within the normal limits. There is no signs of an hydronephrosis in that case. So moving towards the next case, this was during a strict lockdown in my district, and I was very happy with this case because this case was been referred by a public servant. Even they knows the importance of homeopathy during the emergency situation. A 67-year-old man developed pain in the left flank. There is no radiation of pain. and severe lightning pain which lasts for longer duration, presence of nausea, and increased urging of urine. And typically, he has a pain at the end of urination. There is no hematuria, and bowels are unsatisfied, and there is no history of fever. Patient is under medication for inflammatory polymyositis, CAD, diabetes, and hypertension. So what can be the possible diagnosis with the presenting symptoms? Yeah, first, Dr. said that lemon as left renal colic, possibly, and renal colic, calculi, renal colic, renal calculi, possibly. Sorry. Left renal calculi plus iron nephrosis. Yes, that's a very good point. It can be possible. So we prescribed the initial medication as a Candaris 30 without going for any investigation because he was having a severe pain, along with Epismellifica 30. 3 pills for hourly for the 5 days, and we also advised for the urine routine. Candaris was given based on the urging and the violent pain, and before and after the urination. And the Epis was given along with the frequency and the reduced outflow and similar like pain. So 5 days it was okay. He reported me on the 18th while in the morning and says that he has a reduced pain. So 28th he came and he went for urine evaluation. Even we asked for to do it. That is one of the major drawback what we get it actually, because once the patient is better, they are very hesitate to go for a follow-up. Follow-up of investigation. So on 20th, he presented like pain is better and nausea slight better, but no fever, and intensity of pain is reduced and there is no radiation. We asked her to continue for another 5 days, and we even asked again if he has a pain. If you have the pain, do go for a urine evaluation, and sometime we may need extra investigation. On 23rd, he developed a severe pain in the left lower quadrant, and pain has a radiation to the thigh, which has the urine urging has been increased, severe nausea, and feverish at night, and there is no hematuria. So we advise for the USG KUB, and we could find this. You could see that there is a left vesicular junction calculus which measuring about 10 millimeter with left distal ureter dilator. And there is also other features like gallstones and grade 3 fatty liver, and also mild clostridomegaly. He is on other medication, along with the medication for the longer period for the inflammatory polymyositis, I think nearly for 15 years plus. So we started the medicine. We just shifted the medicine because of the last symptoms. We started Pereira Bravia tincture, 5 drops hourly, along with hydrangea tincture, 5 drops hourly. As you know, the hydrangea is one of the strong breaker, and both remedies are good for renal colic, but hydrangea has a specific action and the seat of action towards the ureter. And one of the left-sided with a frequent desire, along with the Pereira, was a radiating type of pain, especially to the loins and thighs. So we described Pereira as well as hydrangea. He continued the medicines, and Sunday he called me and said it was a severe pain, unbearable pain. and he asked what to do. Soon after his call, he sent a text that the stone has passed. And I even asked to undergo a follow-up of USG, but he didn't. So stone has passed. 10 millimeter in size that you can see in the screen. The diagnosis was so. Moving to the next case, 50-year-old female complains of pain in the right loin, radiation of pain across abdomen, no nausea, frequent urging for urine with burning pain during the urination. She had a history of hematuria, and there was a hematuria which present now, and very thirstless, so urine flow is very reduced. We had been started the day she visited Apis mellifica 3 pills hourly, along with Homoeopathy tincture 5 drops hourly for 3 days, and we advised for the urine analysis. And she was instructed to me go for a CT. She wanted to go for a UT, and she told me that I doubt I have a renal calculi, and I wanted to go do it. So yes, we can have a go for it. We considered Homoeopathy based on the hematuria, urging, and the pain across abdomen, and the Apis with the burning, frequent urging, and with reduced heart flow. And this was on 27th. She reported the complaints of better, and with the CT report suggests that there is an obstructed calculus, impacted calculus in the right UV junction, which also causing the moderate right hydronephrosis and hydroureter. We can see the varying size of and both kidneys, the renal calyx, which can be seen 8.2 into 5 millimeter on the right and left, which has been 11 into 8 in the left kidney. So I just shifted from Apis because it was better with the flow, and shifted to the berberis because of the radiating pain, and we shifted. We have been given the Homoeopathy along with the berberis, and berberis was given in the potency 200 3 pills hourly, and the Homoeopathy was given in the tincture form. And this is a follow-up of the patient. We can see there is no obstructed calculus in the right UV junction, and there is no hydronephrosis and no hydroureter. No hydroureter. But we can also see that there is a bilateral renal calculi. But the previous size compared to the present size has been reduced. Like before, it was 8.2 into 5 millimeter in the right, but now we can show as a 4 into 3 millimeter. In the left, you can see as before it was a tiny calculus along with 11 into 8, but now it is 9 into 5 as well as 4 into 3. That was a case of her. So this is just going for another one more case of a renal calculus, which has been 9 millimeter calculus, which found at left vesico-ureteral junction. And there is also small left renal calculus. And we had given with symptoms like hydrangea and Apis mellifica. And we could see that 9 millimeter stone has been passed, but there is a presence of what we could see in the small left renal calculus that also been seen. Sorry. And this was a case which was been admitted in the hospital, and it was been passed urine 4 millimeter. That also in the right UV junction which present. I'm sorry for the interruption because there is a problem in the internet. Is it audible?
Yeah,
Hello?
you're audible. Yes, yes, you're audible. Please share the slides.
Okay. Sir, is it okay? Is it visible?
Yes, yes, it is visible now.
I'm sorry for the interruption. This patient has been traveling and he has a pain and he has a reduced urine outflow, and we had given the basic remedy Candaris as well as Eclipse, but he was just better with the urine flow, but not with uh, the pain. So we went to the CT scan with KUB, and we could find that there is a two small calculus which is present in the bladder, and we had started the bladder calculator remedies. The most stated action of acid benzoic 200, which is in the aqua form. We have been prescribed 10 drops in hourly. On follow-up, we could see that there is no stone which is present in the bladder. This is a case which came to me on very recently, 3 weeks before. This case actually I want to share, it is just one tries to say that importance of a physician not just treating a disease, but also to assess the diagnosis. I always remember my teachers used to say when during internship on final year and third year, always a physician focus is on for the not only for the treatment, also for assessment for the diagnosis. And this was something related to something like that. She came to me, she was consulting for the last 3 months. The scanning was done on the April, and she was consulting all sort of doctors, urologists as well as, and they are also giving the medicine, but the pain was not better. And we were suspecting something else. In the next follow-up, we could see that. So initially, she had a presentation like burning urination and pain in the left iliac region, and severe dysuria and reduced outflow. We have started the same like herpes mellifica. And soon after taking the medicine, she was better. And on follow-up, actually, after a week, I had done the follow-up, and we could see that there is no calculi, which was been seen. Even though it is a very small calculi in the previous scan, but all the doctors suggested that it can be due to the calculi issues of pain. But in the later scan, it was been identified there can be a possible effect of pregnancy and can be subserous fibroid. And the day she undergone the scanning and the reduce was little bit hard to do for the probe tenderness, since after she developed the pain. So the assessment what we got was that to go for a surgery, but she was not willing to go for a surgery, and she wanted to know what exactly she has. So to confirm that she was having any kind of effect pregnancy, we just went for beta HCG, which is very less than 0.100, very negative for that. So since after giving a 1 week of medicine, there is no pain, which was very, like for me, it was like no, is the right way or something is going wrong? So I have been discussed with this case with my colleague, Dr. Agil PG, regarding this case, and also one of the doctor from Alapi, Dr. Ashwin Panikar. And possible outcome, what we can see is, we could find in the left CTS, non-communicating left rudimentary horn with endometrium. So we had discussed with the gynecologist. So possible complication, what we expect can be an endometriosis. And they asked, okay, it is not urgent to do for an emergency surgery because as such there is no pain, and keeping a signal, that correct signal, if she has any kind of pain can have a report, but it is a very less rare to get such pain. That was reference given from the gynecologist. So if we didn't undergo any extra step from the previous USG, or if we didn't went for beta HCG, that can be operated. So you could have saved one with a proper investigation. That's what we learned from the Father Mullers, how to go for a diagnosis and for the treatment. So treating a renal calculi is always good, but we also know that once we get the rural postings, we also seen that from the urologists that renal calculi patients keep coming after operations and they instruct their diet. So we have a remedies to prevent the renal calculi, but we also instruct the diet. We also advise the patient to drink sufficient water, maybe around. And we also ask the patient to eat some kind of a dairy products, 2 to 3 servings per day. Will help the low risk of calcium stone formation. You can eat along with the meals. And moderate amount of protein, because high protein intake will cause the kidneys to excrete more calcium. So therefore, this can cause more stones to form in the kidney. And what not to eat? High sodium diet. We can limit the salt intake, canned and preserved foods. Spinach, berries, chocolates, nuts, beans, tea should be eliminated. And calcium supplements should be limited. And if you have an history of uric acid stones, you also need to limit the red meat, organ meats, and shellfish for a period of time, because there is a high tendency of developing the renal calculi. So we'll be moving for another case. I'll just skip this case and I'll come with this case very later. If I didn't get a time, I will do this. Okay. This was my initial one of the oncology case, which was been very interesting, and it was very, sometimes very challenging to see this case. Patient undergone the CT on 2016. You could see there is a ill-defined heterogeneously enhancing mass lesion, which is noted in the left upper lobe, which is involving the left upper lobe bronchus and resulting in its cut-off and complete collapse distally. The mass is measured around 5.4 into 4.9 centimeter in size. It is seen to infiltrate the mediastinum, which is encapsulating the upper lobe pulmonary artery as well as the left superior pulmonary vein. On inferiorly, the lesion is extending till hilum, and there is no evidence of aortic encasement or no cardiac infiltration. So this is a case of a 73-year-old man who's a farmer, and the gist of symptoms which I can give is throughout the condition was a tough wheezing, bronchoria, and he had a 2 ways episode of pneumonia and dyspnea and chest pain and vertigo. Throughout this case, initially we had been treated with the Banerjee protocol, and later on we had been followed the same. But in between the acute phase, like severe exacerbation of the symptoms arise, we used to admit the patient. Especially we admitted 2 ways because of the oxygen level drops very easily. We admitted once. In the initial stage, we started the oxygen along with antimonium Rs 3x and iodoform 3x. Clinically, I found very good result using just a drop, increase the oxygen level antimonium 3x in powder as well as adaform 3x in powder. So with the presentation, the reason we admission was a reduced oxygen level. He presented with a cough, rattling, and the breathing difficulty, and which was worse by lying down, and cough without expectoration, and there was a temperature around -99. So during the admission, the oxygen level was 79, and so he had a kind of breathing difficulties. So we started the nebulization with arsenic amalgam 3x, the 2 drops, which is mixed in the nasal solution 5 ml for 60 seconds. We also given a medicine along with antimonium ars and adaform. We also given a medicine of antimonium tartaricum and Apis mellifica 3x, which is with a diluted with the distilled water. We started the IV because to maintain his weakness. And after 24 hours, we could see that oxygen level has been raised to 85. Complaints of cough and the breathing difficulty was reduced a bit. Weakness is improved. We continued the medicines and we shifted to the room. Cough with profuse expectoration and the breathing difficulty was improved and wheezing is reduced and oxygen level was raised up to 89. So once the oxygen is raised up and once the breathing difficulty has been reduced, we removed the Apis mellifica and we started Ipecac 3x along with antimonium tartaricum 30C, which is repeated very hourly. So on the next day, we could see that cough, which is improved along with expectoration, and the breathing difficulty has been improved, as well as the wheezing has been improved, and the oxygen level was raised up to 93. So we discharged the patient after 2 days. We had given a medicine like Ipecac and antimonium tartrate 4 times a day, and antimonium arsenicum 3x and 1 dose in the morning, and adaform 3x 1 dose in the evening. And we had an history. I mean, we also had admitted once the same patient for the same complaint, and we faced in similar way. And we undergone a CT on 2017. We could see that the left upper lobe lesion, which is noted in the previous study, has been resolved, but the present study shows a nodal mass in the left hilar region, which is narrowing the bronchus and possibly infiltrating the pulmonary artery. Since after this report, we could see that sometimes there can be breathing difficulties occurred. So one of the remedy which I used to prefer was the aspirosperma, which has a direct action towards the pulmonary artery, and it has to recover soon after it takes it. And since after 2017, we didn't do any kind of investigation in the sense like CT scanning procedures, because after the scanning he was a bit of mentally weak and he was not willing for it. So this was a video which I took before my presentation in ICIO during the March. He was back to the farming. What the homeopathy can offer is, without having a chemotherapy and radiation therapy, is back to the farming. We monitor this patient with the CBC, ESR, and CRP, and I would say that he had a weakness, and lecithin 3x has been used for whenever the weaknesses are raised, because it has improved generally along with the hemoglobin. We focus with the CEA, carcinoembryogenic antigen, to assess the prognosis, and we also monitorize the expectation of the secondary symptoms. Since after the second admission, we used to give a veratrum viridum 200 SOS to keep if he has any kind of a fever, because also to prevent the pneumonic stages. and now is under the Bannerjee protocol remedy Calicap 200C along with the antimonium tartaricum 30C. Moving to the next case. 42-year-old female who came with features. This was a to take up such cases. Actually, we are gifted, and our batch was very gifted. We used to see in third year, final year, and internship similar cases. So it was a very damn confident to take such cases. Even we got a good exposure in the St. Anthony's under, I remember the Dr. Shara ma'am. And coming to the case, a 42-year-old female. She don't have any kind of sensation around the foot. This was, the picture which was been taken during the clinic. We could see the maggots present and severe offensiveness, and no symptoms of pain or burning. And even she is not getting any kind of sensation while touching the whole leg, the dorsal aspect especially. And so with the limited features like severe offensiveness, loss of sensation around, there's a possibility of maggots again, and no symptoms of pain or burning. So with these features, what can be a first remedy at your mind? Diabetic foot is a diagnosis. Severe offensiveness was the present one, and loss of sensation, and there is no symptoms of pain or burning. Yeah, Maxo, Aptesia, opium, pyrogen, syphilis, which initiated injury externally as well. But we have started a remedy called carbolic acid, which our exposure at the college is one of the powerful irritant and the anesthetic remedy, and it's one of the foul and painless destructive remedy. And we had started carbolic acid 30 in hourly, and this is just seen after 24 hours. We could see that the offensiveness is a bit reduced, but she don't have any kind of sensation around, and there's no pain or numbness. And this is after the 4th day. Offensiveness reduced, started to get a pain in and around, and we could see the fresh blood. Even the previous week, we can see the fresh blood around. We could see the diabetics was fluctuating when we check in for the fasting as well as random. So we asked our hospital diabetologist to look into it. So Sarah suggested for insulin therapy for a period of time. And this is a pic before and after the removal of the second phalanx bone. It's done by the general surgeon at the hospital and our hospital. And most importantly, Sir was advised that it is no need to recur for antibiotics now because it's the full condition of healing. So let it go. So there is a very positive sign which I found from my surgeon. So we started with calendula 30 and we drawn the acid carb 30. And we could see over the night, the day it was, one has been removed, we could see there was a rise in the temperature, and we could undergo a ESR and CFP, which was a bit raised, and we prescribed a dose of pyrogen, and half glass of water, and ask the one teaspoon to repeat in every hourly. And yeah, this is on the 10th day we discharged. That was first peak you can see on the left. We undergone an MRI of the right foot ankle. You can see on the third image that bit of swelling that is mainly due to the dislocation of the third metatarsal joint. And you can see, we can also find that there is a diffuse soft tissue edema in the foot angle and distal leg, and also bit of an ankle joint effusion in the MRI. So the dislocation, we refer to the orthosurgeon. As you say that now we may not be doing for a surgery because the history of diabetic uncontrolled, it may take another time for healing. So he had just postponed it. So meanwhile, we had given the Bryonia 30 and the Simfidin 30 along with it. And we also done the investigation of both arterial as well as a vein Doppler to know the blood supply, and it was perfect. So I felt that was a very reason to have a for the proper healing has taken. She has been advised to amputate the leg from ankle from one hospital. She has been advised for amputation from the knee. Our own remedies could save from amputating and just lost one toe. And she's not under medication of now. She's under allopathic medication for the diabetes again. And I had seen her very recently. And it was perfect to say, like, and the diabetes is controlled, and she has been monitoring the diet. And she has a larger farm because of the reason she said before, that was the reason to develop diabetes. Now she's looking after her well. And this is what homeopathy offers. Can I go for the last case, or we have a time? Hello?
Yeah, you can present the last case. Yeah,
okay.
You can present it.
Yeah, thank you. So the case is, which I skipped, was not much explained, so I just skipped the case. The case came to a teacher with the presentation of a teacher, 38-year-old teacher. He has came with a postness. So he has been treating under allopathy medication for the 6 months for the vocal cord polyp, and but there was no change. So they advise surgery, and patient started to observe that he has a loss of voice during the last session of each class, each day, especially if you need to take any extra class, extra hour during any teacher absence. So you need to use the extra effort to produce sound. Usually he used to take a class around 5 hours, and we undergo, and there is no history of breathing difficulties, or there is no addiction, and there is no thyroid diseases. So when this came to me, I had a feeling to reduce the symptomatology at the initial stage. So with the features, like I didn't mention any of these the constitutional character here, because the case concern which has not received, because this case has been presented in an event. During the time also, I asked for the consent, that the teacher was not given the consent. So I just presented with the data. So we had given the phosphorus 30 based on the features, and we had repeated for 3 times a day, and the diagnosis was the peduncular vocal cord polyp. we continued the medicine for 1 month post-respiratory, and we could see on the follow-up that hoarseness has been improved. And also he suggested that episodes are reduced. And he could find that the medications were irregular, and we repeated the medicine for 1 month again. And on the next follow-up, we could find that hoarseness better and there is no complaint as such now. So we advised for the endoscopy again. So we raised the potency to 200 weekly doses. And this report became, I think, after 4 or 5 months, the report has been sent to the clinic. We could see that there is no signs of any polyp, any vocal polyp. And this is all about my presentation. And I sincere thanks to all my teachers, because what we learn from the college is ultimate. Thank you.
Thank you, Dr. Amir. I think now you may take some questions. Actually, there were a few questions from our participants. That one thing is mainly regarding the appendicitis. Someone asked for any tips for appendicitis, and one more thing is regarding the appendicitis. Most of the cases, what we saw, you prescribed the belladonna initially and the 200 potency. That was one of the main remedy you prescribed. So is there any, is it like any protocol you are using, or is it, or symptomatically, what is the main basis of that prescription?
The behind giving belladonna is nothing but the inflammatory process. The case is coming in a fresh hand. It's not delayed. So the inflammatory remedies act well. So that's the reason I was giving the belladonna.
Okay. Is there any other protocol which you follow specifically?
The protocol which I see, there's no protocol which I was learned. Read from the book Farrington. That sulfur 1 was can curative for the appendicitis once you give the sector remedy. That was the reason giving sulfur 1.
Yeah, whether the sulfur 1 whether we give after the acute episode or because your first prescription we saw it
is along with the prescription.
Okay.
It was given bilaterally along and also after the acute phase.
Okay, and there is another question that what size of renal calculi usually we will be able to treat with the homeopathic medicines without going for any lithotripsy? Maximum size?
That is a very difficult, because there are a lot of doctors who treat a higher number of renal calculi. I consider mine was highest was a 15 millimeter. Okay. And only thing is that if the patient is able to tolerate the pain, because the pain will be very severe, we could see it can be a male labor pain. What we say is that, so with our remedies, pain has been controlled, then it can break and it can pass through it. That's what I see in my last 6 years of clinical career.
Okay, another important point is most of the prescriptions we had seen you giving the treating the acute condition, but whether after that have you followed with any of the deep acting medicines, or what was further like renal calculi, even though if you treat with the acute medicines, after that what was follow up actually in the follow up, whether you are going to treat with any deep acting medicines? Or
out of 10 cases in the OP, 8 will be acute. So I mainly go for the acute phase of the treatment, and the cases which I treated, I may be seeing them later, but for the another acute, they're not under my treatment for the chronic conditions. So even appendicitis, they will be treating for other conditions. We'll be going for routine scan if we find that there's a pain, but no other such apart from the sector remedy. Only sector remedy was given.
Okay, fine. Then any experience of treating any staghorn calculus in
no,
your practice?
There is no such treatment of staghorn calculus so far for the last 6 years, to be very frank.
Okay, fine. Questions from the participant side? Yeah, I think by that we can wind up the question answer session, I think. Anyway, we are very thanks to you, Dr. Amir, and it was a wonderful session, especially to see a lot of difficult cases, or what we call surgical cases. Usually, most of the cases are usually sent for the surgery, and I can see that the passionate, being so passionate and encouraging it is for our students, and also the young homeopaths who comes out. Maybe the experienced doctors will be able to treat those cases, but being a youngster, many a times when we get a new case or when we get such acute cases, we have little hesitation to take up those cases. And in you, I could mainly see that you have that courage and you're there to take such cases and show certain results on that. Here we are not going to talk about the classical homeopathy over here, but patient comes to you with a lot of belief in the system. Okay, it is our duty to what to say, give the results to them with our system. So in that way, you are doing a wonderful job, and I think it encourages our young students and also the young doctors in the field. Actually, thank you so much for this wonderful presentation. Now,
Thank you, sir, for giving an opportunity. And ultimately, it is our teachers who gives us strength. Because ideally, we always say that teachers, those who takes risk, they may face failures. Those who don't take risk, they won't face the failures.
yes, that's what. That is one thing we could see, because in your practice you had a variety of cases. Because we know when we start the practice, it is difficult to get that variety of cases until and unless you take the risk. Okay, because we can just practice with the common fever, joint pains, and all those things. But what will happen? You'll never get any such kind of different cases, difficult cases. But here you had got many number of challenging cases. Actually, that is because of your that passion what you keep. Anyway, keep it up. Okay, all the best for your future also. And now over to Dr. Gino.
Thank you. Thank you, Dr. Amir Ashraf, for your wonderful section. It was a very interesting, and I am sure there has been a lot of learning from you. Now, I extend my warm thanks to our administrator, Reverend Father Roshan Krasta. I also thank our principal, Dr. Shivaprasad sir, and Vice Principal, Dr. E.S.J. Prabhuran. Finally, I would like to give a special thanks to Dr. Hafiz for moderating today's section. Special thanks to the organizing committee members headed by Dr. Dheeraj Ignatius Fernandez and technical team of ProVision Series 2020. We will be joining you again tomorrow for the next section by Dr. Rajat on the topic Utility of Pocket Manual of Homeopathic Materia Medica in day-to-day practice at 7:30 p.m. With this, we'll come to the end of today's section. Thank you. Good night.